Hello, everyone. Today I have the honor of interviewing Dr. Michael Greenberg. Dr. Michael is a licensed clinical psychologist who specializes in the treatment of OCD and anxiety disorders, and the director of OCD Associates, a practice specializing in rumination focused exposure response prevention therapy. Welcome, Dr. Michael. I'm so excited to have this conversation with you.
Thank you for having me. I'm excited to be here.
Okay. Okay. Um, let's start with the famous Carl Jung once talked about the idea of the wounded healer. It seems that we study what pains us. So before you ask any question, tell us more about who you are, your own journey, and what brought you into doing what you do today.
Yeah. I've shared in many contexts in the past that I have OCD. Um, and I think that there's always been a parallel process between how I was trying to help myself and how I was trying to help my patients. At first, I learned ERP, and I was doing that with my patients. And to be clear, it was helpful to me and to them, but it was limited for me in the area of rumination. It didn't really tell me what to do about all of the like compulsive thinking that I was doing, even though I read all of the advice that was available about that. So I tried to figure out how to apply ERP or how to apply cognitive behavioral therapy to rumination. And I came up with something that I think is useful, and that works in that regard. But then, and I thought at the time, I thought that was um, the whole picture because I was sort of within this, I would call it omnipotent fantasy shared by a lot of people in the OCD world that ERP should be a total treatment for OCD. I'm cognizant of who, can I ask you a question? Maybe you'll, do you edit this afterwards? Are people who are listening to this like English speakers, or do I need to kind of try to talk
No, no,
in
no. They
simple?
were no, no. It will be translated into Arabic with subtitles. So speak freely.
Oh, it's going to
Ah,
be translated. Okay.
ah.
Okay, good. Okay, that makes sense. I was wondering. Okay. All right. So, because I'm like, who am I talking to? Um, okay. So basically, so I did, I learned, I learned about ERP to help myself. I used that with patients. It helped me to significantly, it helped them significantly. It didn't really tell me what to do with all of this though. It helped me with behaviors, but didn't help me with what was going on mentally.
Mhm.
So I spent several years trying to figure out what to do about that, but within the framework of CBT and ERP. And I was still within this sort of mindset shared by a lot of the OCD community that ERP is all we need for OCD. And I think that what I came up with was really helpful. But then as I continued to live and to apply the skills that I'd come up with, I confronted the limitations of how helpful they were, that they were helpful to a degree, but they weren't the whole picture. So specifically, that work was about how to stop ruminating. And I found that, in fact, it is possible in any given moment to stop ruminating. That is really possible. That no matter what's going on, you can make a decision to stop and you can turn it off. And I can show people how to do that. But what that didn't address is sort of the drive to ruminate and the anxiety that's driving you to the sort of unconscious anxiety that's making you go there in the first place. And so, yes, you can just shut it down, shut it down, shut it down, but that doesn't really address the forces that are compelling you to do it in the first place. And so, um, around the same time, I was getting interested in psychoanalysis, probably for a combination of reasons. On some level, at least unconsciously, probably I already had a sense that I needed more help than I was getting. But I also have colleagues who are psychoanalytic, and I would talk to them about cases, and I would just hear that they saw things and understood things about the cases that I didn't understand. So I was always interested in it. So I started doing more of that, learning more of that. I started psychoanalysis, and I started understanding more of the emotional factors that were going on for me and also in my patients. And so that sort of led to where I am now, which is trying to integrate psychoanalytic perspectives into treating OCD, which I find to be extremely helpful. It's been extremely helpful to me, and I think it's been extremely helpful to my patients. So that's basically um, what my journey has been thus far. Does that answer your question?
Yeah, it answers enough. Okay, so explain to the audience who don't know much about OCD. Uh,
Hmm.
in your own opinion, what is the essence of OCD? It's like, is it, for example, just a severe level of anxiety? Is it a maladaptive coping mechanism to fear? What is your theory? What is the theory that best
Yeah,
explains OCD?
yeah. I think it's both of those things. I think you can think about it on a number of levels. Um, in DSM, which is the American sort of list directory of all psychological disorders. It's separated out from anxiety disorders at this point, but I think that it's most accurate personally. And I should say I'm not a research statistics guy. I'm a theory and clinical guy. So in my conceptualization of OCD and my work with OCD, to me, it seems most accurate to think of it as it's an anxiety disorder. And I don't think it's too different from other anxiety disorders. What is notable about it is sometimes some of the concerns, the things that people are anxious about, are more sort of out there, like a little more unusual. And whereas somebody with sort of generalized anxiety disorder, the concerns might be more mundane. But I don't think personally, I don't see them as being qualitatively different disorders. I think
Mhm.
they're sort of the similar underlying dynamics. And sometimes, the person who is obsessed with whether they are a murderer, right? That has an OCD flavor. The person who's just worried about their presentation tomorrow or worried about this or that or the other thing, we might be more prone to call them GAD. But personally, I don't see those things as so separate. Okay. So I would think of it definitely as an anxiety disorder. There's definitely something very repetitive. Well, I should say something before any of this, which is OCD is not one thing. So
Mhm.
you can have two people with OCD who look very different from each other. You can have one person who doesn't do any compulsive behaviors, at least externally. Okay, they're not doing anything that you can see, but inside they're sitting there trying to figure out if they're going to kill you because they're terrified that they might have an aggressive feeling towards you. Not that, to be clear, not that any of these people is dangerous. They're not, and they would never actually do those things, but they're terrified. What if? And you could have somebody else with OCD who is just feels like a weird feeling in their neck that makes them go like this, and they have to go like that because it doesn't feel right until they do that. So those two people both have OCD and are like sort of both uh, 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 great examples of OCD, even though they have nothing to do with each other, right? On some level, meaning unconsciously, when you think psychoanalytically about what's going on for them, there's a lot that's similar, but just on the surface, they're not similar cases at all. So um, we're collecting my thoughts. So basically, yes, it's an anxiety disorder. It has a certain flavor, but I would think of it as just a certain variety of anxiety disorder.
Mhm.
Yeah.
Okay, so let's speak about the etiology of it. How much OCD is connected to, for example, the attachment theory and the early childhood traumas? Does these things explain the origin of the OCD, the etiology of the
Hmm.
disease? Want to hear your opinion about that.
Hmm. Yeah. So I think whenever we're talking about things like the topics you just brought up, we have to be careful not to be reductive, and not to be too linear in how we're thinking about it. So, for example, if we were to say early attachment issues lead to OCD, that would raise a lot of questions. Like a lot of people have early attachment issues. They don't all develop OCD. right? People have other disorders. People develop other disorders who don't develop any disorder at all. So I think that no matter who you ask, psychoanalytic or otherwise, we would say it's a combination of factors that leads somebody to have OCD. That can include, for sure, a genetic predisposition or a temperament. There are people who are just more predisposed towards one condition or another for a variety of reasons. And there are also somebody like me who's psychoanalytic would say there are clear patterns across people with OCD of having certain types of conflicts early in childhood. And specifically, more often than not, or I would say actually maybe almost all the time, I just don't want to make any sort of extreme statements, but what we see in people with OCD is that there is a history of a fear that certain healthy, aggressive feelings will in some way alienate them from other people.
Mm-hmm.
So, yeah, so if we're talking about attachment means our sense of emotional connection to other people. So people with OCD generally have some life experience that has led them to feel like certain aggressive feelings, and to be clear, I mean healthy, normal aggressive feelings, are not something that can be welcomed in, okay, in a loving, close relationship, that those feelings would threaten that relationship. So
Okay.
if
So
you
it
are,
has something to do with
yeah.
agreeableness. People who are so agreeable that they cannot say no or express their aggression in a healthy way.
So there's something to what you're saying, but I think it sort of implies a causality that I wouldn't
Yeah.
say is correct.
Mm-hmm.
Not that a person is born agreeable and therefore develops OCD. It's that when you describe someone as agreeable, part of what you might be saying is that this person doesn't exhibit aggression. Maybe this is a person who doesn't say what they want, or who prioritizes other people's feelings, or who doesn't say when they're upset, or who doesn't even know like what their preference is, right? Or doesn't get mad if somebody treats them badly. You might describe that person as agreeable, but from an analytic perspective, we would say that person is defending against all of those feelings. It's not okay to have all of those natural feelings that they do have, because everybody has those feelings, but they're not able to be conscious of them. Does that make sense?
Mm-hmm.
Maybe I think the model that I find most useful now for thinking about this is Winnicott. Winnicott's an analytic theorist from the middle of the 1900s. Okay, he's a
Okay.
very prominent psychoanalytic figure, and basically he the way the way he described the way that we develop, Winnicott described the way that we come to understand and experience our own feelings. Something like this. Let's say when a baby is hungry, okay, the baby cries. And I've said this other places, so to anybody who's heard this in another place, I apologize for repeating myself. When a baby is hungry, the baby doesn't know that they're hungry. Okay, they just have a direct physical feeling of hunger in their body. They don't know what that feeling is. They don't even know that they are a self. They're just having an experience. Okay.
Okay.
And if all goes well, the caregiver comes along and says, "Oh, you're hungry," and then feeds the baby. Okay. So what the baby eventually understands over time is that these physical sensations, oh, that's called hunger. And then they have a thought to go with that feeling. So instead of this just being a physical sensation, they can think about what they're feeling. And based on the mother or the caregiver's response, they learn that it's okay to feel hungry. It does not alienate the other person. It doesn't overwhelm the other person, right? And so they have an idea, an understanding of what they're feeling, and they know that it's safe to feel that in a relationship with somebody else. And they can integrate that into their sense of themselves. I sometimes feel hungry. Okay. So the same thing happens with other feelings. For example, if I'm feeling angry or envious or whatever it might be, and I have somebody who says, "Oh, you're feeling this," right? And that's okay. Then I understand what it is, right? It's not just a direct physical experience. I have an idea to go with it. And I know that it's safe to feel that in relationships. Okay. But if I don't have a caregiver who understands that feeling, or I have a caregiver who reacts to that feeling like it's scary or bad or overwhelming, then either I never develop an understanding of this feeling, or I develop a sense that this feeling is not safe because it threatens my relationships with other people.
Hmm.
Then what I have to do is I have to develop some sort of defense mechanism to get rid of that feeling. Okay. So from this perspective, you could think of OCD as a defense mechanism that allows me to get rid of a feeling. So, for example, let's say I'm someone who feels like it's not okay to be angry at someone you love. Okay. And let's say that's because from the time I was an infant, I like the reaction to my anger was bad, right? It wasn't a caregiver saying you're angry, it's okay. It was a caregiver going like they didn't like that. It made them anxious or overwhelmed or they didn't understand it or whatever. So OCD, let's say I develop an obsession that the stove is on,
Hmm.
okay? And the stove is going to burn down the house and kill my family. What might be going on, and I'm not saying this is in every case, but as an example, what might be going on is let's say this is a person who is scared of her own anger. The obsession displaces it, it turns it into something else. Instead of having an emotional problem, I'm angry and I'm scared that that will, ruin my family or alienate me from my family. I become obsessed with whether the stove is on. And then I try to turn it off, turn it off, turn it off. But it's really a symbol of a feeling that I'm trying to get rid of. So I displace my anger and my anxiety about my anger onto the stove is on and there's gonna be this fire that burns down the house and kills my family. So it's a displacement. It moves it away from an emotional problem inside of me to another problem. And then it's what we call an undoing, which is another defense mechanism, which is trying to shut down a feeling. So I turn it into the stove is on, and then I keep on trying to turn off the stove. And so um, this is an example of how we might think of a conflict about a feeling turning into an obsession about a stove and trying to turn the stove off. I worry that what I just said was not clear and that I went too far too fast. Was that comprehensible to you, or was that too much too soon?
Well, yeah, I understand it like 70%.
Okay. Okay.
Because
Let me back up
I
for so let forget the stove for a second. Okay. Forget the
uh
stove. Forget the stove. Okay. I had a feeling that it didn't feel welcome in relationships. It felt like it alienated me from relationships. So I'm scared
okay,
to feel that feeling. Okay.
okay,
So I felt conflict around that feeling and anxiety around that feeling. So that's what we mean when we're talking about somebody having OCD, having conflicts around aggression. We're saying this is a person who, for whatever reason, was scared that their feelings would alienate other people, would make other people go away, would make other people fall apart, would make other people hate them, whatever it might be. Let's pause there. I went too far.
okay. So next is they turn these feelings into what happens next? These feelings that they don't
So the
they that they,
OCD
oh okay,
Mhm. So the OCD, so we start with a conflict. I know I went way too far, way too. Do you want to back? Should we back up? Should we like
no,
roll
it's
it
fine, it's
back? I
fine.
went.
Let's continue this.
Yeah.
Oh,
So I start with the conflict. Okay. I'm not allowed to feel certain feeling,
hmm.
and then what the OCD does is it's a combination usually of two defenses. Okay.
Okay,
No, I'm jumping. But people listening don't know what a defense is. I'm going way too fast. Let's bring it back. Let's bring it back. Okay. Let's go to whatever your questions were, and maybe we'll come back to here later. The point is, OCD has emotional roots, okay, in conflicts around aggression and attachment, where
hmm.
a feeling of aggression, threat, and attachment make you feel like scared, like it's not okay to feel those feelings. And what the OCD does is we'll get into that later. Okay, it starts there. Does everybody who has a conflict around aggression have OCD? No.
Mm.
Okay, pretty clearly not that. If we did a study and we said we looked at all the people who have somehow we measured conflicts around aggression, and then we said, do they all develop OCD? I would argue probably not. First of all, because there are so many other factors, but also because there is clearly some predisposition that's there also. Why one person develops OCD and another person develops, I don't want to trigger anybody, but other disorders.
Mm. Okay. So also, I feel like OCD is the disease of the thinkers, of the people who are smart. Um, I wanna hear your own opinion about in the 12 steps they say that one of the illnesses that people have in the 12 steps and the addicts in general, that they are trying to control the universe.
Yeah.
They are playing God. How does OCD
Mhm.
relates to this idea that it's like I'm
Yeah,
not
that's good.
I'm not surrendering control. I'm trying to have everything thought and planned and
Mhm.
tell us more
Yeah,
about
that's
that.
a great question. That's a great question. I think that you could answer that on multiple levels. Okay. On the most basic level, you could say, take somebody who is terrified that if they eat a certain food, it could cause cancer. Okay.
Mm,
They're obsessive about, oh no, I can't eat this or that, it's going to cause cancer. That person is also someone, but through that anxiety, that person also unconsciously underneath that has a sense that if I am very careful about my diet, I can prevent myself from getting cancer, right?
mhm,
So when I'm being anxious about what I eat because it might cause cancer, my conscious experience is that I'm scared, but the flip side of that is that I have some control, right? So you could say that the flip side of every anxiety is what we call an omnipotent fantasy, a fantasy of having more control than I really have. Or let's say if I am praying for something compulsively, okay, um, and I'm terrified that if I don't, or let's say if I'm terrified I don't do XYZ ritual, prayer or otherwise, just something, that something bad will happen, right? The flip side of that is that as long as I do these things, I'm somehow preventing it from happening. So on some level, you could definitely see a lot of OCD as an omnipotent fantasy. And you could also see it as providing control on other levels as well. It's an attempt to control emotionally. So people with OCD consciously and unconsciously are trying to curate, meaning control and manage their emotional experiences. Um, Sometimes that manifests. Okay, I don't want to get to, I'm getting to, I need to calm down.
no, it's
Um,
fine.
so
Continue, it's
there's
fine.
control of emotional, there's a way that it's trying to control emotional experiences. There's a way that it's trying to control experiences in the world. And there's definitely also a way that because obsessive compulsives think very much in terms of ideals and right and wrong, and develop an idea that there's a right way to do things and a wrong way to do things. Because of that, other people also experience obsessive compulsives as controlling, because obsessive compulsives apply this right wrong framework to things that involve other people as well. So you could think about control and OCD on a number of levels.
Hmm. Okay. So okay, let's move into. I think we talked about enough about the etiology of it. Let's move into a very important subject, which is the psychiatric interventions for OCD. Okay, I've recently interviewed a psychiatrist who is called Dr. Joseph Vidoring. I don't know if you know him or not, but uh, he he um, he's someone that helps people to taper off their psychiatric meds because he discovered the the corruption in the psychiatric field in general. For example, antidepressants being antidepressants. The pharmaceutical companies tell people that they have an effect on depression, and they treat that SSRIs treat less low serotonin and all of that, and this is just an illusion.
Let me jump in. I'm
Ah,
not a psychiatrist.
okay, I know.
I don't, and so I don't know if the things you're saying are true, not true. I have no idea. I don't deal with this stuff. So
Okay, it's
maybe
fine.
I don't
Mhm.
want to. Yeah, I don't want to get into psychiatry because I don't know what I'm talking about.
Okay, so when you are treating your patients, do you often refer them to psychiatrists to get an SSRI or something like that to help them with the depression, with their anxiety? What is your take on psychiatric interventions for OCD?
Um, I think it's a very personal decision. That's I know people who um, have been very helped by SSRIs or by whatever medication they were prescribed. People find these things very helpful. I know people who have not found them as helpful. I know people who have gotten better on medication, and I know people who have gotten better without taking medication. Um, so I think usually, in my experience, most people already have a feeling that they either do or don't want to be on meds. That's my experience with my patients. Most people either they already are on meds or they want to be on meds or they have a psychiatrist or they really don't want to. And I don't push people one direction or another. I leave that to between them and their psychiatrist. If somebody wants a referral to psychiatry, I'm always happy to provide one. And I'm not yeah, I think it's just a personal individual decision.
Hmm. Okay. Okay. Okay, let's jump into the main topic. So what do you think of what do you think about the already
And
existing okay.
I'm a
Go
little
ahead.
nervous to I'm a little nervous to say anything about medication at all because I feel like it's really not my area.
Yeah,
Yeah,
I understand. I understand.
take it out. I don't want to comment on medication.
Okay, I really respect that. Um, okay, so what do you think for about the existing therapies for OCD? Are they efficient? You know, there are very popular things like ERB, accepting commitment therapy, ICBT, and normal CBT. What do you think about these therapies, and do they really work?
So I think that people with OCD, myself included historically, but hopefully less now, we're very prone to thinking in binary terms. Like, is it a good
Mm,
treatment or a bad treatment? Is it a perfect treatment or a terrible treatment? And I think that the reality is more dimensional. So, for example, ERP is a very good treatment. It really helps people. We have evidence that it's very helpful to a lot of people. But does it help anybody all the way? Not that I know of. And does it help everybody? No. If you looked at the research on ERP, we would see that it is helpful, somewhat helpful to many people. It's not all, I don't think somebody can correct me if I'm wrong, but I think in the research studies, I don't think there's anybody who is completely better from ERP. And I don't think that it helps everybody in the study. So it's somewhat helpful. Okay. People with OCD, because we tend to think in all or nothing terms, they think, oh, if ERP is a good treatment, it should solve all of my problems. And they get ERP and it again, it's very helpful. It can really change a person's life, but it's not going to solve everything. So that's ERP. Um, ACT, I personally have some grievances against ACT. I think that some elements of ACT practiced by certain practitioners a certain way are probably helpful. Um, I have an article on my website where I identify some of the concerns that I have about ACT. I don't think that ACT is my overall problem with ACT is that telling somebody to accept their symptoms bothers me because I think that it's our job to help people get better from their symptoms. And I don't like the idea of learning to live with your symptoms as sort of a treatment, if that makes sense. It
mm,
makes that my feeling about it, and I could be wrong, but my feeling about it is that sort of people confronted the fact that ERP didn't know what to do for certain things. So then they introduced ACT to tell people to just learn to live with their symptoms. And I don't like that, maybe because I'm an idealist and I want to believe that we should keep working at developing a better treatment instead of just learning to live with symptoms. You could poke holes in what I'm saying. You could say, okay, but what about now? And what about somebody who still has symptoms? Like, don't they need to learn to cope with them? So I think that's all fine as long as it's sort of not seen as the final word. As long as it's just like coping skills now, but that's not, in my mind, that's not, I don't want to say things that are too black and white. That's not how I think about treatment. Learning to live with symptoms is not how I think about treatment. I want treatment to be something that actually makes things better. So I have some issues with ACT. I also think that certain ACT interventions can actually be problematic and make people worse. I think that ACT's ways of dealing with rumination are not effective and sometimes could potentially keep people stuck. So I have some specific problems with ACT and that I've discussed elsewhere. But again, I also know good practitioners who use ACT in a helpful way, fine. So I don't want to be too black and white about it. ICBT, very clearly people say is helpful. Okay. But again, it's helpful. It's like ERP, it's adding something. So the reason that I'm most interested in psychoanalysis now because I think that psychoanalysis has a framework for conceptualizing what's going on that none of these other approaches has. Like these other approaches don't really have a way of conceptualizing what is the real nature of this problem? Why does a person have this problem? And because it can't even conceptualize what the problem is, it can't really do anything about it. So, for example, if these other approaches don't have a theoretical framework that can understand that this person has a conflict around aggression and where that comes from and how we treat it, right? Then they're never going to be able to help with that. Or like if the person who's turning off the stove, right? None of these other approaches would have a theory of why they're doing that, as far as I understand. Certainly not ERP, certainly not ACT. I don't know much about ICBT, but I think ICBT would have like a little bit of a theory that there's this feared self, but that's not really, I don't think that's complex enough to capture the whole thing. And psychoanalysis would have an idea of where this is coming from that would allow you to then address that underlying issue. Okay, so I like psychoanalysis because I think it offers a more accurate, full understanding of what the nature of the problem is that allows you to get at the real underlying problem. Okay, that doesn't mean that psychoanalysis is perfect. It doesn't mean that people should. That doesn't mean that every psychoanalyst is going to be helpful. It's certainly not a quick fix. But in my experience as a patient and as a therapist, it's extremely helpful to people. And it can sort of see things in a way that these other approaches cannot see it. Like if psychoanalysis is about sort of seeing the sort of abstract emotional patterns of what's going on, where is this coming from? What is this really about? What's going on emotionally? That allows you to intervene on a deeper level. And again, in my experience and in my patients' experiences, at least a lot of them, I think, if not all, it's very helpful. Okay. So it was the original question, what I think about these. So I think basically, I think that I think we need to think in terms of what is helpful versus what's ideal. Okay. But if I'm honest, I do still hold on to some omnipotent fantasy that psychoanalysis can really solve the problem more fully than the other approaches. So ask me in 10 years and I'll let you know if that was the case.
Yeah, of course, it still needs to be researched enough.
I just meant ask me after 10 more years of analysis and I'll let you know.
Yeah. So let's talk about the idea of exposure and why do you don't believe that it doesn't work with OCD? For example, I will tell you something personal.
No. Hold on. No. I believe that exposure works for OCD. Who said I don't believe that exposure works for OCD?
Because from my own understanding, because it doesn't stop ruminations. So rumination.
So it might not, it
When
doesn't
I read
address,
your articles,
it doesn't help with rumination.
okay. Ah.
It helps with other parts of it. It could maybe change somebody who's going like this all the time, or somebody who can't put a diaper on their baby. It could help a lot with those things, which are also OCD, but it doesn't help with what's going on up here.
Oh, so let's talk about this area. For example, I used to have a social anxiety, fear of speaking in public, and all of that. And as I practiced this more and done some public lectures, and uh, it became a normal thing. I don't have fear of public speaking anymore. So what is the missing? So what is the missing area, or what is the missing parts um, in just doing exposure to people who are having OCD? What is the idea behind rumination focused ERP?
In other words, you're saying you had an experience of exposure working for you.
Hmm.
So why doesn't exposure work in all cases?
Okay.
Is
Why
that
exposure doesn't stop ruminations and treat anxiety totally?
okay? Um, Give me an example of somebody with OCD, like, or I'll give you an example of somebody with OCD. Somebody with OCD, let's say, is afraid that they're gonna murder their spouse, or they're afraid
Okay.
that they're a pedophile, or they're afraid that they're in the wrong relationship, or they're afraid that they're gonna get cancer. Okay.
Okay.
So exposure for these things, the way that it's traditionally practiced, might be uh, I guess I'm giving too many examples to give. Let's say somebody is obsessed with whether they're a pedophile, okay, which
Okay.
is a CD symptom. To be clear for anybody listening, they're not actually pedophiles. They're just like terrified. What if I am? What if I'm feeling? What if whatever? So, so the exposures might look like going near kids. The exposures might look like not avoiding watching TV that has kids in it. The exposure might look like changing a diaper on your kid. Okay. Um, Traditionally, the exposure might, like in traditional ERP, the exposure might also look like reading scripts about molesting a kid over and over and over again. Okay. And
Hmm.
the idea being that you're somehow going to habituate to this idea of being a pedophile. None of these things usually actually stops a person from continuing to wonder if they're a pedophile, continuing to worry about that. Okay. It might change their behavior. It might allow them to do things they didn't do before. In some cases, it might show them that something is not a problem. In some cases, it might stop them from ruminating about this or that, but it doesn't usually stop them from like uh, it doesn't stop this process. It doesn't stop the internal constant questioning and doubting, et cetera, et cetera. So I think that's the answer. Like exposure is helpful. Exposure can help somebody stop to worry about certain things in certain cases. But in, I think, the majority of cases of people who have who ruminate, who are treated with exposure, they're still ruminating afterwards. I mean, I think that's the basic point. Maybe it would change what they're ruminating about. Maybe they wouldn't worry about this as much as that. Um, Maybe they learn something, maybe they can do more, but this is usually still happening.
Okay, so we as humans, we don't get tolerated to negative feelings in general, So, uh, for example, if I feel an anxiety, it doesn't make me in the next time to feel less anxiety in the next time. So so we can't
Right. I
get
mean,
you we can't get used to negative emotions as we get used to positive emotions. Um,
in other words, the short answer is no. Like you don't habituate to emotions.
okay.
You don't
For
habituate to
example, we
anxiety.
habituate to pleasure, but we don't habituate to pain.
I think the reason I'm having trouble answering this and the what's what I think the what makes things complicated in this conversation is that the word habituate is so broad, right?
Hmm.
So, for example, you're talking about getting used to doing podcasts, so you're not as scared anymore. But then at the same time, you're talking about like I think you're talking about the hedonic treadmill,
Yeah,
right?
yeah,
Or that we go back to.
exactly.
And I think it's correct to use the term habituate in these different contexts, but I think it's not the same thing in all these different contexts. Like, you're not, like, for example, the hedonic treadmill, you're not habituating to happiness the same way as you habituated to doing podcasts. It's a different thing entirely, or like habituating to getting used to having a routine every day, you could say is habituating, or you got whatever. So maybe it's too broad because your questions are good, but I'm having trouble answering them. I think because maybe we're talking about a lot of different things at once,
Hmm.
because this word is a pretty broad word that can capture a lot of things. And maybe that even honestly raises a good point about traditional ERP, that it thinks about this idea of habituation too broadly.
Hmm.
Like even in traditional ERP, it's unclear, are you habituating to the anxiety? Are you habituating to the stimulus itself? So it's not always clear what exactly we mean by habituation. Um, yeah, so I think that's why I'm having trouble answering the question. But going back to do we habituate to feelings? Um, we definitely don't habituate to anxiety. And the evidence for that is that you see a lot of people who are anxious their whole lives. Like if
Yeah.
you habituated to anxiety, then they would eventually stop being anxious. So I think of anxiety as the consequence of a behavior. They're ruminating. And okay, if I'm thinking on a cognitive behavioral level, okay, if I'm
Hmm.
thinking on a psychoanalytic level, it's a whole different story. But if I'm thinking on a cognitive behavioral level, I would think of rumination as the consequence of a behavior. And it will just keep on going as long as you keep doing that behavior. As long as you keep on ruminating, you're going to be anxious, and you could ruminate for the rest of your life and you could continue to feel anxious.
Okay.
Um, so it's sort of like traditional ERP would say, let's be anxious on purpose because that way you'll habituate to that feeling. And I would say that that is sort of like saying to someone, let's say somebody's eating a food that's giving them a stomach ache. We would never say to that person, well, let's keep eating that food and keep getting a stomach ache so you can get used to the feeling of having a stomach ache and then you'll habituate to that feeling. We would say, if you're doing something that's giving you a stomach ache, let's stop eating the food. So that's how I would think about rumination and anxiety on a cognitive behavioral level. You're doing a behavior that's causing your anxiety.
Hmm.
Does that make sense?
Yeah, it makes sense. Um, so to get to the next question, uh, is rejuvenations like a friend of mine who told me to he encouraged me to make this interview. Uh, he thinks that his ruminations are involuntarily, that it's just something that he cannot stop. So
Yeah, so
how to
that's
how, how
exactly
to
that's
stop ruminations? Is that even possible? Is
good.
it even
Good.
possible to
Yeah.
stop
So that's
ruminations?
yeah. Yeah. So that's exactly who I'm talking to. Okay. People with OCD who ruminate think that this is something that's happening to them that they don't have control over. Okay.
Hmm.
So the basic framework is like this. Rumination is analytical thinking. It is a person who is trying to figure something out. Somebody who's ruminating is always trying to figure something out. Okay. There's a question that they need to answer. The person is doing it because even though on some level they want to stop, on another level, they think that there's value in answering this question. Okay. In
Mm-hmm.
fact, they think that there is urgent value in answering this question. They must ruminate, they must figure out the answer to this question. Otherwise, something bad will happen. And if only they can answer this question, then they can prevent something bad from happening. Okay. So they're trying to answer a question, they're trying to figure something out, and they think it's very important. Okay. And that's why they keep on doing it. Now, they'll say, but I want to stop. That's true, but you also want to figure it out. So you're trying to stop and you're also trying to figure it out at the same time. So it's like if you were holding a basketball, I don't know, a soccer ball, I guess, in Egypt, very tight, and also trying, I guess you wouldn't hold a soccer ball. I guess this whole analogy falls apart. So, but let's say American. It's like if you were holding a basketball and also trying to drop it at the same time. Okay, that's what's going on for your friend. He says, I want to stop and I can't. It's just happening to me. But if he really were to reflect, what am I trying to figure out? What is the question that I'm trying to answer? And what is my idea that I have about why that's really important? What he would recognize is that he's actually actively trying to figure this out on purpose. He desperately wants an answer to this question. And then when he's trying to figure it out and he's also trying to stop, that's when he gets stuck and he feels like, whatever, I can't, whatever.
Mm-hmm.
If he were to make a decision to stop, you can't have it both ways. You can't hold the ball and drop it at the same time. If he were to make a decision to stop, he could stop. He could actually stop. He might get stuck in certain ways. Okay, there's an article on my website that goes through how to navigate some of those technicalities because sometimes when people are trying to stop, they're still holding on in certain ways. But broadly speaking, it's about making the decision to stop instead of trying to have it both ways at the same time, trying to figure it out and drop the ball at the same time. Does that make sense?
Okay. Yeah. So,
Your friend doesn't realize if he thinks it's just happening to him, he doesn't realize that he is trying to answer a certain question.
yeah. So he can have these ideas in his awareness, but he doesn't have to pay attention to them to turn them into ruminations, right?
For example, our example from before of the person who's afraid that they're going to murder their spouse, okay, or that they're a pedophile, this question might exist for them. What if X, Y, or Z? I don't know the answer to that.
Mm-hmm.
That's the obsession. It's then trying to figure, okay, would I, how do I know? What was that feeling? Like trying to answer this question, that is what makes them anxious. That's rumination, trying to figure that out. The question existing is not rumination and will not make them anxious. The question is trying to answer that question, going through their day, looking at all the kids, trying to figure out what am I feeling? Why am I feeling this? How do I stop feeling this? What should I do? Right? That is rumination, and that's what makes them anxious. That's what makes them subjectively, when a
Okay.
person feels anxious, what they're telling you is that they're playing with it. They're in their head trying to figure this out. They're ruminating. And if they were to let go of trying to figure this out, they would feel calm.
Okay. Let me try to play
Does that
the
make
let me try to play the devil's advocate here. I will defend him in a more strong way. Okay.
yeah.
The problem with, I believe, you know, that when there's a famous line in Harry Potter when he went to
I wanted
heaven,
to
you
say
know.
I appreciated that Harry Potter is on the same shelf as all these other very important books. And I agree that it should be on the top shelf, and that's very good.
Okay. I really respect that you get it right. Okay.
But which
Okay.
ones did you select? I see only two. Which ones made the top shelf?
Um, okay. It's the Chamber of Secrets.
Chamber of Secrets. Okay.
Ah,
And what's the other one? I see.
it's also the Philosopher's Stone. I still don't I did I don't have the full collection, but I'm
I, I just have the full. Then you have all these other books that are less important. Okay, fine. Go on.
no.
Okay.
I've read I mainly I have read I've read it PDF, but I don't have the
Oh, you
hard
don't have the
copy.
physical.
Uh,
Okay, got it. Got
I
it.
already
Okay.
have those two. Okay, it's fine. So return to our scene. Harry Potter was talking to to the professor, to Dumbledore. So he told him, Professor, is this real, or it's just happening inside my mind? So he told him,
Beautiful scene. Yeah,
okay. So he
so
told him,
beautiful. Uh,
who said on earth
uh,
that because it's happening inside your mind, it's not real. So the problem with people who have OCD, as I
uh-huh.
understand, somehow they identify with their thoughts. They think because I'm thinking about something, it's real. It's real. It's
Yeah.
something real. It has
Okay.
something to do
So
with me.
yeah, I think there is some truth to what you're saying, but I don't think it's the whole story. So we could have specific types of OCD. This is what you're saying is a very ICBT concept, and I'll tell you where I think it applies. We could have somebody who is we could have somebody with OCD who is convinced that they hit somebody with their car. Okay. Or
Hmm.
we could have somebody with OCD who's convinced that they did something really bad that they can't remember. Or we could have somebody with OCD who's convinced that they're going to hurt their spouse, that they're actually going to do it. Okay. And then we could say, well, none of these things is actually real or actually happening, etc. But we could also have somebody with OCD who looks very different from these people, who just says, I'm not worried that I'm actually going to hurt my spouse. Okay. But I have this feeling that I want to, and I don't know what to do about that feeling. What does this feeling say about me? This feeling is what's terrifying, right?
Hmm.
Or I have a sexual feeling that I don't know what it means and it's terrifying to me, or it makes me worry XYZ. So I I don't think that I think that in some cases we could say that a person is believing their imagination. That's like what ICBT does. But I think that that concept is a little bit limited to certain cases. I don't think that that's going to really be helpful in a lot of OCD cases. Does that make sense? Or somebody who's going like this because they have the discomfort and they have to go like, I mean, like somebody who has like a just right OCD, where they have a physical sensation that they have to resolve.
Hmm.
Certainly, that person is ruminating about that physical sensation, but I wouldn't say that that person like believes their thoughts too much. So uh, I don't think about, I'm not sure that's the most helpful framework for thinking about it.
Okay. But
Can you give me
because
an example that you
I was
have in
speaking, I
mind
was
where,
speaking because if I, for example, my friend, he the mere existence of thoughts inside his mind make him believe that, oh my God, how can someone like me have these kinds of thoughts? That
so that's different. So that's different. So that's different. So you're not saying that the person believes their thoughts too much. You're saying that this person is doesn't want to have certain thoughts and feelings, right?
hmm,
That they feel like it's not okay to have bad thoughts and feelings, right? And
okay.
so right, that person is struggling with um, wanting to have too much control over their thoughts and feelings, and thinking that certain thoughts and certain feelings are not okay. And I think that what that person is trying to be all good. And I think that the most important thing for that person is to come to terms with the fact that being a person means having all different thoughts and feelings, good, bad, and ugly. And that
Yeah,
there's
I got this. For example, he may because he didn't talk to many people and knew what is inside of them. So, for example, if
Mhm,
someone is thinking something sexual about his mother or something very weird
mhm.
like that, he may believe that I am the only one who is having these weird ideas. I am the only one who
Right,
has these
right.
weird pedophilic ideas.
Right.
Mhm.
Right. And the more unacceptable it is, the more space it takes up and the more the person tries to get rid of it, as opposed to somebody who's okay having being a person and having all sorts of thoughts and feelings, but have the thought and not think much of it, right? It would be
Mhm.
okay. So I think maybe the way that I would say it more psychoanalytically is that um, people with OCD try to control their thoughts and feelings. And it is healthier and it's healthier to not have rules about acceptable thoughts and feelings, for it to be okay to have any thoughts and feelings and to just control your behavior. Because
Mhm.
ultimately, we're not in control of our thoughts and feelings. And All of us, all humans have all of the feelings, the good, the bad, the ugly, and making room for that and not feeling too bad or guilty or different from other people when you have all sorts of thoughts and feelings, that's the path to mental health. Okay, now
Yeah.
that's easier said than done because if you grew up in an environment where it really wasn't okay to have certain thoughts or feelings, right, or where people made you feel like you were the only one who ever had a certain thought or feeling, you're not going to feel like it's okay to have those thoughts and feelings. And that's where a psychoanalytic treatment is helpful in helping a person to feel certain feelings within a relationship and feel that it's okay.
Mhm. Yeah, there is a beautiful Eastern saying in the Eastern Orthodox Church that it says something like you can't you can't prevent birds from flying above your head, but you can prevent them from making a nest on top of your head. So
I
I
like
believe
that. Yeah, good.
ah
Very good. Yeah, yeah, it's good. So in other words, you can't control your feelings. The more you try to control your feelings, the worse. Okay. Um, but you can control your behavior. And people with OCD, ironically, are trying very hard to control their feelings, but feel like they have no control over their behavior.
mhm.
And so what we want to do is both. We want to show them actually you have a lot of control over your behavior, and we want to make more room for all the feelings and try to have less control over those. Okay. Now, if somebody were listening to this with OCD, they would say, okay, but not everybody has all these thoughts that I'm having. Okay. And on some level, that's true. They're having a symptom, but the basic thought or feeling that's represented by their symptom, everybody has. So, for example, the person who wants to murder their spouse and is constantly thinking about murdering their spouse, oh my God, and constantly thinking about stabbing them, okay,
Mhm.
they're right. Not everybody is spending all day going like that, okay? But other people who are healthier can think, oh, I just want to kill my spouse and then have a cup of coffee and just move on, right? So on
Mhm.
some level, they're right. They're obsessed with this in a way that other people aren't. But on another level, that's because it's not really okay for them to have certain thoughts or feelings to begin with. And that's why they get so stuck. I mean, it's a little simplistic. There's more to it, but it's a basic, I think it's an accurate way of thinking about it on a basic level.
Okay, to return to Harry Potter, I have another beautiful scene. You
I could
know,
do a whole. I'm happy to do a whole episode on Harry Potter. You go right ahead.
yeah, maybe we can schedule a whole show about it.
Right.
Okay.
By the way,
The
occlumency.
psychology in Harry Potter is we can name it the psychology in
OC,
Harry
how
Potter's
about
novel.
how about just the OCD in Harry Potter and occlumency when Snape is trying to teach him how to block out Voldemort?
Ah,
When I read that, I was like, this woman has OCD. I know it. I know it because it's such a perfect description of OCD. And then she said later, more after she wrote Harry Potter, she shared, J.K. Rowling shared that she has OCD or had OCD.
okay.
And I was like, I knew it. I knew it. Yeah. Go on.
Okay. Okay, so the scenes that I want to mention is the devil's snare. Okay,
Uh-huh.
I believe it also beautifully represents OCD because the harder you try to resist these
Hmm.
thoughts, the more it clings to you and the more it holds you. But if you just
Yeah.
let go,
Yeah.
you will get through it.
Yeah. Easier said than done, but yes. Right? Like, meaning I think both. Where I am in my understanding of treatment now is that both are true. There's so much a person can do to help themselves feel better. There's so much a person can stop ruminating. They can make the decision over and over again. We're not doing this. Stay out, etc. And the more and the less they resist, the better. But then I've also come to understand that um, that also needs to happen in the context of a relationship. And
Hmm.
so just telling a person, oh, just let go, just stop ruminating or whatever, it kind of misses a big part of the help that they need. So I want to do two things when I'm talking to people with OCD. I want to empower them, but at the same time, I want to let them know that they need help. In other words, I want them to know that there's a lot they can do to help themselves, which is very important. And there's a tremendous amount people with OCD can do to help themselves. They can help themselves feel so much better And at the same time, I don't want them to feel like if they're not all the way better, it's their fault. Nobody's
Mhm.
going to get all the way better just by not ruminating. I used to think that somebody could get all the way better just by consistently not ruminating. And I've come to understand that was naive and it ignored the sort of underlying factors that are going into things. So, so yes, devil snare and let go and stop ruminating. But also we need to get rid of the devil's snare that's holding on to you, and that's only going to happen in the context of I think a psychoanalytic psychodynamic treatment where somebody can understand what it is that's holding on. A devil snare is actually a beautiful analogy because there is something you can do to get out of it, but also why is it there in the first place? Why is this thing constantly trapping you? Yeah.
Mhm. Okay, to summarize, to
This
so
is,
to
I think,
sum,
one of my, say
go
again.
ahead, go ahead, go ahead.
I was going to say, I think this is one of my worst and most disorganized podcasts I've ever done. So I apologize to you.
No, no, no. I am enjoying it. We are talking freely about many different topics.
I think I think I've like jumped ahead too much. I'm like instead of sticking to basics, I'm like I think I'm so in the psychoanalytic perspective these days that I have to sort of remind myself about other things.
Okay, to summarize this, we can say that OCD is largely a product of trying to control the mental processes you can't control, while failing to control the ones you can and should control.
Yeah, I would say an emotional, mental and emotional. Well, mental is not good because you can control certain mental processes, right? Like rumination. I would say um, OCD is about trying to control your feelings too much, trying to control what thoughts occur to you too much, and also thinking that other people don't have these thoughts and feelings, and thinking that if you have these thoughts and feelings, you're bad or unacceptable, and not realizing that that's just kind of what it is to be a person, is having all sorts of thoughts and feelings, and that's sort of the state of being human.
Welcome to
Um,
humanity.
and what?
Welcome to humanity.
Welcome to humanity. But that's a memo that most people with OCD didn't get. They think that they're supposed to control their thoughts, supposed to control their feelings. We really believe this. So learning that no, that's not true and that's not healthy and that's not anybody. I like to say anything that you're feeling, other people feel too. There's no experience you're having that other people don't have. You're just more scared of it. So I think that's on the one hand. And yeah, I would say not and on the behavior side, losing track of the fact that they have control over their behavior. People with OCD are trying to control their thoughts and feelings and then feeling like their behavior is out of control and they have no choice. And we want to restore their agency on the behavior side, show them, no, no, you do have control. You can stop this. And also help them to make more room for all of the different parts of being a person on the inside. Yeah.
Okay.
And you can think of a lot of their behavior. This is what I started with too early. We're thinking analytically, their efforts, what's going on behaviorally is a manifestation of trying to control what's going on emotionally.
Mhm. Yeah, so
Okay.
basically you help the person. It's like the Serenity prayers. Of course, yeah,
Yeah.
yeah,
Yeah.
something like that.
Yes, exactly.
It's okay.
Something
I
like
want to
that.
accept
That's
the
right.
things.
Yeah.
I want to accept the things I
Yeah.
cannot
Yeah.
change, and I want to change the things I can. Mhm.
But I also want to say to that person, the things that you can't change that are happening for you, I also want you to know that they're happening for everybody.
Mm.
I also want you to know that you're not the only person having this feeling, even though you might be struggling with it more than other people, or it might become this whole thing that it doesn't become for other people. But the fundamental feeling that's underneath it is something that everybody feels.
Okay. Uh, I want to jump into a very close topic of OCD. The addiction and compulsive behaviors. People, for example, having like people struggling with compulsive sex, compulsive masturbation, compulsive eating. How does
Mhm.
this translate with with your own view
It's a great,
about OCD. Is this also classified as OCD?
great question. Okay, great question. So there's a lot of disagreement. I don't even know if it's disagreement. There's a lot of mess around the words addiction and compulsion. Okay. People will use the word addiction to describe eating or, like you said, masturbating or, I don't know, whatever. Okay. And I'm not saying that's wrong. Okay. Like very intelligent, academically impressive people use those terms, and it's not wrong to call those things addiction. Personally, I personally only use the word addiction to describe situations where there's a chemical dependency, and
Mhm.
otherwise I use the word compulsion. If somebody is eating, it's not in my way of thinking, that's not an addiction, that's a compulsion. If somebody, okay, so I would never say that somebody had a porn addiction. I would never say that. Because if a person stops watching porn, they're not going to go into withdrawal, right? There's no chemical dependency. And somebody will say, oh, but the dopamine, but it's not the same thing. You're not going into withdrawal. Nobody is going to be hospitalized or need whatever Narcan or whatever because they stopped watching porn. So it's not in my book, it's not an addiction because there's no chemical dependent, there's no physiological dependency. So therefore, the way I think, I would think of all of the rest as related to OCD. But again, like OCD is just a construct, right? So is it correct to say that OCD is the same thing as somebody who is a compulsive eater? Or OCD is the same thing as somebody who has a sex addiction, or what people would call a sex addiction, but I would call compulsive sexual behavior? Um, I don't think that those things are best characterized as OCD.
Mm.
Okay, but I think that there is definitely something in there's something in common there. OCD, compulsive behaviors, addiction, eating disorders. There's a lot of overlap. Okay, psychoanalytically, there's a lot of overlap, even though there's also distinctions. And I also think that when it comes to compulsive behavior, and this is maybe the most important thing to say, I think that the interventions that we use for OCD, rumination focused ERP, where we help people to the way that we treat certain OCD, like just right OCD when somebody has an urge, right?
Mm.
I think that the way that we treat that can be applied to these other situations very effectively.
Yeah.
Okay, because basically in other approaches, what we do is a person has an urge, and the way we approach it is that the reason that that urge keeps on going is because the person continues to ruminate about it, to debate, to do it, to not to do it, to do it, not to do it, and that's what keeps them in this state of fixation. And that if we can teach them to stop ruminating, and when they have the urge to disengage, that the urge can go away. Okay, this is not true if there's a physiological dependency. Like if there's a real addiction, the urge is not going to go away. There's a physical need to smoke. There's a physical need to whatever. Okay, but it can address the mental fixation. Now,
Mhm.
again, I'm talking about a cognitive behavioral level. On a psychoanalytic level, there are deeper things that need to be addressed. Okay, putting that to the side, on a cognitive behavioral level, this person has an urge and then they get fixated on the urge because they're like, am I going to do it? I don't want to do it, but I need to do it, etc. And we can use our intervention that we use in OCD in other compulsive behaviors. So, for example, I had a patient several years ago who had a porn addiction. Again, I wouldn't call it an addiction, right? But what one might call a porn addiction. And basically, whenever he had the urge, he felt like he was powerless to not do it. And what I showed him is that he could have the urge. And then instead of sitting there going like, oh, I don't know, am I going to do it, not do it, to just disengage, that showed him that he could walk away from the urge. Okay. And it really helped him. Now, do I think that person had other issues that they needed to do more work on? I'm sure. But it took him from someone who was powerless whenever he had that urge he was powerless to not do it. He became someone who could have the urge and could disengage and walk away. And
Yeah,
think
so
that was a very
the
powerful
same
intervention.
thing like with OCD, I can have the urge in my awareness, but I don't have to pay attention to it. Okay. I get this
Yes,
right?
yeah.
Okay.
And if you let go of it, the urge will wander out of your awareness.
Mm-hmm.
Yeah.
Okay, this is interesting, but that they don't it's really interesting you not using the addiction terminology. Okay, many
But again,
people.
I'm not claiming that I'm right and other people are wrong. It's just a word. You can use it however you use it. Personally, I think it's important to draw a distinction between physiological dependency and not. So to me, to me, I don't use the word addiction for anything else, even though I have used it several times since I said that.
Okay, so we didn't talk enough about rumination focused ERP. So if you want to summarize it to someone who wants to try it, how will you
Yeah.
summarize this kind of
Yeah.
treatment for both OCD and
Okay.
addiction? So we want to talk about it
Rod,
in
your
this
questions
level.
are good. Your questions are good. They're too good. I can't answer them. They're too good. I'll start with the first part and then we can talk about the second part. So, let's say we had someone who is terrified to hold a knife around their loved one because they're afraid that they will stab their loved one. Okay.
Mhm.
In traditional ERP, we would have that person hold the knife near the loved one. And when they feel really anxious, we would say, good, we want you to feel anxious because then this is in traditional ERP, not the way I do things. Okay. We want you to feel anxious because then you'll get used to that feeling. Then you'll get used to holding the knife. And then if you feel anxious, your anxiety will eventually go away. Okay. You'll habituate to the anxiety. Does that make sense? Okay, that's
Yeah.
traditional ERP. In rumination focused ERP, we would say when that person is holding the knife and they start to feel anxious, what's really going on is that they're standing there ruminating. They're holding the knife and they're ruminating and they're going, am I going to stab them? How do I know? Oh my God, what's happening? Do I want to? What was that feeling? Oh my God, I really am a murderer. No, I'm not a murderer. I just have OCD. I don't know why I feel this way. Am I whatever, whatever, whatever. Okay. That's what's going on in the background when they're feeling anxious. So we would say to that person, when you're holding the knife, doing the exposure, we want you to stop doing that, turn it off, stop trying to figure out any of that. And then their anxiety is going to go way down, hopefully go away entirely. Okay.
Okay.
So that's the difference between these two approaches. In both of them, where the person is afraid to hold a knife around their loved one, and we're saying you're going to hold a knife around your loved one. That's the exposure in both cases. But in the traditional ERP, we want that person to feel very anxious while they're doing it, because that's how we do habituation. And in this approach, there is no habituation, or at least not to anxiety. And what we want a person to do is hold the knife and not ruminate and not feel anxious and learn that if they're not doing all of this, they can hold the knife around their loved one without feeling anxious. So very similar approaches externally, behaviorally, but internally, there's this different relationship to anxiety.
Okay. So how does this
One of
apply
these
to
approaches,
a
yeah, go ahead, go ahead.
no, we continue. I'll ask it later.
One of these approaches wants anxiety because they see that as important in how the treatment works. And the other approach, my approach, wants anxiety gone because we see that as reflecting the fact that a compulsion is happening.
Okay. So also the second example, how this apply to behavioral compulsions like what we call addiction. Um, how can this
Yeah.
for, can you give an
Okay. So
example about someone for example struggling with masturbation, so compulsive masturbation? How
I'll give
can
you,
he how can this be applied?
I'll give you, yeah, I'll give you a simpler example. Let's say somebody has simply, when they have the urge to, they have an urge to tap. When they have that urge, they
Hmm.
have to tap. Okay. You can have somebody who says, if I don't tap, I'm afraid my mother's going to die. Okay. That's a different story. We're not talking about them right now. You can have somebody though who when they have the urge to tap, they don't think anything bad is going to happen, but they're afraid they feel like this feeling of needing to tap is not going to go away until they do it. Make sense?
Makes sense.
So, okay, so what we would say is So what the traditional approach would do is they would trigger the need to tap, and then they would sit there and not tap. And they would feel anxious, and they would just wait for that feeling of anxiety to hopefully eventually go away. That's the traditional approach. In our approach, we would say, you're missing what's going on behind the scenes. The person has the urge, and then they're sitting there going, I need to tap, but I can't tap, but I need to tap, but I don't want to tap, but I need to tap, but this will just be over if I tap, and I don't have another way of not feeling this way. They're sitting there ruminating about it. And so our approach adds, we're going to trigger the urge and we're going to not ruminate about it. We're going to disengage. We're not going to go through this, yes, no, yes, no, we're not going to do that. And then you're going to see that the urge to tap goes away. And then you find out this person previously thought that there's no way out other than to tap. That was how we started. But now we're showing them that there is another way out. They can disengage mentally, and then the urge goes away, and then they don't have to tap. So again, very similar. They look very similar. Trigger the urge, don't tap. But in one of them, in ours, we're addressing the rumination piece that's perpetuating the urge, and we're showing them that there's another way out.
Okay, I got it. So, for example, if we apply this to something difficult, such as pornography addiction, which is so common these days, the person can have the urge, but
Right?
not ruminating about it.
Exactly. Instead of having the urge and then going, oh, but I want to, but I don't want to, but I shouldn't, but why not? But it'll make me feel better. This isn't going to go away. I know I'm going to do it eventually. Why not just get it over with? We can go have the urge. I don't want to do that, or I'm not doing that. Turn it off. We're not engaging, and then go do something else.
Okay.
Now, again, if we're thinking, so that's only on a cognitive behavioral level that we can make the urge go away. On a psychoanalytic level, the person with the porn addiction, clearly there's more going on there, right?
Exactly.
Clearly there's this emotional factors that are driving them to watch porn, which, isn't necessarily anything terrible. It could be that this person, let's say, um, uh, is having other feelings that they don't really understand and they misinterpret as horny. Like maybe they're just bored, burnt out, depressed, overworked, uh, don't know what to feel dead. Like maybe they don't know what to do to feel whatever, but they don't understand any of those feelings. And what comes to mind is just watching porn. I mean, who knows what this could be? It doesn't have to be anything perverted. It can just be like simple feelings that are not differentiated and not understood, and they don't know what to do with them or how to solve them. And so their best understanding is this or whatever. So without going into that, because this may be beyond the scope, on a cognitive behavioral level, we can take that person's urge and make it go away. We can teach them that they can turn off the urge.
Okay, great. Okay, I see that we are running out of time, but one last thing, I really see that it's missing.
I have until 10.
Okay. So there's that thing that I see that is still missing in your own ideas to get it more into the public, to be acknowledged by the public opinions. They know how are you planning to do research about rumination focused ERP? What is your plan about researching it and proving it to other people on a scientific level?
Yeah. Yeah, a few years ago, I made a plan to do that. And I was going to work with an OCD researcher who's a lovely guy and wanted to take it on. But when we started meeting together, sort of laid out what would be involved in doing this, that would involve a lot of work on my part that I basically just, I don't feel, I should do it intellectually. It would make sense to do empirical research to prove XYZ, but everybody has limited resources. And what I'm much more passionate about is I'm much more passionate about theory. I'm much more passionate about, like right now, I'm spending a lot of time writing, but I'm not doing empirical research. I'm writing up some of the psychoanalytic ideas that I've learned that I think are useful and I want to put out. I'd rather put something out there for people to read and use if they find it helpful and get them interested in what psychoanalysis can offer. I'd rather I emotionally am more driven to spend my time on that than I am to prove something that I already know is true.
Yeah,
So
it will speak for itself.
what?
It will just speak
Yeah,
of
yeah. I
itself.
think
It will
that
prove itself right by the clinical
I,
clinically speaking.
yeah. I think so. I think so. I think that's right. I think again, it's not rational. You know, rationally, if I made it, what would be the most effective way to have impact, et cetera, et cetera? Maybe it would be to do an empirical study, but I see a full caseload of patients. I supervise a number of therapists. I run a practice. Um, and so I have limited time for writing. And what I really care about is getting new ideas out into the world, so that it's there and somebody can find it and use it, and less about proving, empirically something that is not new, you know? So
Mhm.
I'm not saying right or wrong, but I'm saying that's the situation. I'm not dedicating my time to it. In several years, maybe will I have a sense that I've gotten all of the writing done that I wanted to get done, and now I can dedicate some time to something else. Maybe, or maybe somebody else who's trained in this will take over and do the research. But personally, I've recognized that I have limitations on time and energy, and I'm not motivated to focus on those things right now. Yeah.
Are you planning to write something like a book, or are you just focusing on articles right now?
So, um, first of all, I'll say writing is very hard for
Yeah,
anybody.
I know it.
Anybody that writes is really hard. I have this article that I'm writing now that's sort of I have, let's say, 10 articles, drafts that I want to publish. Um, but right now I'm working on one of them, and I have pages and pages written that need editing. It's sort of like if you're anybody who bakes, sometimes you have to put something through a sieve over and over and over again until you get all of the pieces out. So it feels like that. It's like I already have the basic thing written, but the editing and the fixing and saying it just right, etc., it takes a tremendous amount of time. So of all of those, let's say 10 articles that I have drafts of, I'm working on this one. I've been working on it for months and months and months, even years, really.
Wow, wow.
And I think hopefully it's all done. Hopefully it's almost done. And I'm really hopeful it could be out. And I don't even want to say it because every time I say a number, it's wrong. But maybe a couple of months, I don't know, a few months, it could be done. And so I don't want to wait until I have everything gathered for the sake of what's the point of writing a book? To say I wrote a book? Like that's nice, but it's
No,
not what
it's
motivates me.
like connecting ideas together into a single
Yeah.
structure,
So I
something
think
like that.
the way, the way that I think about it is I want to write up all of these ideas. Each one as it's ready, I want to put it out and make it available. And then maybe eventually I'll collect them all together and
Hmm.
sew them
Yeah.
together into a book. But if I die, I'm not going to be upset that I didn't write a book.
Oh,
I'm
I
going to
got
be
it.
upset that I didn't get these ideas out into the world, so the priority is getting ideas out into the world. And if that ends up looking like a book at some point, that'll be cool, but it doesn't keep me up at night. You know what I mean? Like what really bothers me is things that I have learned and put together that I haven't yet shared. That really presses on me. Yeah.
Okay, great. So so finally tell our audience how can they find more about you? How can they read your articles? Um,
Yeah, I mean, I have a website that has a lot of resources on it, and I'm working on adding more. But like I said, it is very time consuming. So they can look at what's there now, and they can sign up. There's a place to put your name to be notified when there's a new article. So yeah,
Great. Okay, it was a pleasure to have you here, and I really
it's
enjoyed
nice to meet
this
you.
conversation. And of course, one day we need to make a whole episode about Harry Potter. Okay. it will be very funny. So we can do something fun, like an episode about the
Okay.
psychology in
Oh, an
Harry Potter
episode about
books.
Harry.
Uh,
That's funny. Yeah, very
okay,
good.
we can schedule that one day. Okay.
Yeah, love it. Oh, so nice to meet you. Thank you for your time. I'm sorry that I was a little bit disorganized. I hope you're able to make it comprehensible.
No, no, it's fine. I enjoyed it. Okay.
Okay.
It was
Nice to
great to
meet
have
you.
you. Nice to meet you too. Goodbye.